ahead. Hi everyone, welcome to another Wednesday VMR. I'm so excited. It's Sharmin here. I have the distinct pleasure of discussing with Sarah today. Hey Sarah, thank you so much for being here.
Yeah, I'm so excited to discuss with you. I feel like I'm a little bit nervous that I'll say something that, is misinformation or but I'm excited to do my best.
Don't worry. Misinformation is part of learning and we'll correct it and learn together. It's just that's part of medicine. We just gotta keep thinking out loud, learning from each other. So do not worry about that. We just gotta go. We're gonna have a lot of fun and you're gonna be great. Perfect. Big shout out to Dodmer and Jillian for scribing and doing teaching point. And Mohammed, thank you so much for joining us. Do you want to introduce yourself to the VMR community?
Hello, everyone. I'm Mohammed, medical graduate from Iraq, and I'm excited to present a new case to VMR.
Amazing. Thank you so much for joining us. All right, if you can get the board up, we can get started. Thank you, Jillian. All right, Mohammed, the mic is yours.
I have about five alquats, and the fifth alquat including the diagnostic test and the diagnosis. So let's start with the patient chief concern. This is a 20-year-old male presented to the clinic with chest pain and shortness of breath for 2 years.
Wow, quite a young guy, Mohammed. This is a very interesting start. Sarah, what are your thoughts?
Yeah, this is really interesting. I feel like most of the time when I'm thinking about chest pain, I'm thinking about it in the acute setting, where I'm kind of thinking, let's rule out the most common or scary causes of chest pain first, and then kind of, go through by organ system, thinking about the heart and the lungs and the chest wall and like referred pain that might come to the chest as a result. This is interesting because, like, some of those things that I might initially think about for that acute setting, I think about in an older patient. So, like, for example, like cardiac, like infarction. Typically, you're thinking of like older patients with like cardiovascular risk factors. So this patient who is a younger gentleman, and is having shortness of breath and chest pain for a chronic timeline. I guess I'm more interested about some of those things that I think about in younger patients. So like autoimmune causes or things that are more like anatomic. So does this patient have some kind of congenital problem that now is coming out of the woodwork as they've gotten to a certain age? Um, so I think without more information about, whether they have like autoimmune things that I might pick up in the physical exam or, the tempo of the chest pain and how it's presenting, I think those are going to be helpful for discerning some of these etiologies. What are your thoughts?
Oh, that was brilliant, Sarah. I totally agree with you. This is the young guy, and in our experiences, young folks don't love presenting to emergency rooms. I'm not sure if this is what a setting this is, but it would be interesting to know, like, if this has been going on for 2 years, what prompted him to come in at this moment in time. So basically, what I'm trying to understand, are we dealing with like a kind of a chronic chest pain, or is it an acute on chronic process? And I really, really love that you still went to a like, ACS, your no misdiagnoses. Yes, he's like for sure too young for like atherosclerotic a disease that we often see turn into like MIs. But there are like multiple different mechanisms from like vasospasm to dissection. If there is any, if it has like any congenital issues or like hereditary issues that would like causing to affect like the integrity of the blood vessels themselves. Those things can like present in young adulthood. And so I still really, really love that 4+2+2, like the four cardiac etiology to pulmonary to esophageal, especially the esophageal part being rupture, impaction, pulmonary diseases, and also like the four cardiac we often like to think about. And I think in general, like still our most of our focus tend to be in like the cardiopulmonary systems to make sure like we're not missing any diagnosis, even someone who's like presenting at a younger age. However, I really love that you were thinking about referred pain, like, in someone who's like 20, if there's any reason for them to be severely anemic that is presenting more with like kind of shortness of breath. However, like I think getting a better characteristic of like both the chest pain and the shortness of breath, is it more exertional? Is it more at rest? And if there's been any changes in character, that would be like really helpful at this point. All right, Mohammed, back to you. You have us on the edge of our seats.
Thank you for this amazing discussion. So let's move on to the HPI and past medical history. This patient is a 20-year-old male who his condition started 2 years ago when he had frequent intermittent episodes of shortness of breath and chest pain. These episodes occurred unpredictably to the patient, either at rest or with minimal exertion, and lasted for maximum of 30 minutes and resulted in frequent admissions to the emergency department. Outside of these episodic chest pain and shortness of breath, there's no shortness of breath on exertion or general or chest pain another time. This patient's last episode of chest pain occurred 2 weeks ago when the patient felt gradually increasing central severe chest pain, shortness of breath, palpitations. That was unlike this episodic pattern. It was continuous. He was admitted to the emergency department, found to be hypertensive, and his EKG showed ST depression in the lateral leads. These changes resolved spontaneously upon his admission to the CCU. He was then, after follow-up, discharged from the hospital with aspirin and clopidogrel, and now came to the clinic for follow-up. This patient review of systems, there is no syncope, cough with sputum, no fever, weight loss, or night sweats. I will complete with the patient past medical history. The patient have hypertension diagnosed 2 years ago, have panic disorder diagnosed 1 year ago, has 2 CCU admissions 2 years ago at the beginning of his episodic chest pain, and also 2 weeks ago. This patient taking aspirin, clopidogrel, and bisoprolol that started 2 weeks ago, and also taking benzodiazepines, PRN. This patient family history is notable for two things. First, consanguinity. His parents are cousins, and his paternal grandparents are also cousins. And second thing, his 27-year-old sister has heart failure and on ICD, diagnosed at the age of 23-year-old. This patient's social and behavioral history, there is learning difficulty. He dropped out of school in the 2nd grade, and also he is dependent in his most of activities of daily living. And this is my second alquat.
Wow, this is so fascinating already, Mohammed. Thank you so much for giving us so much information to work with. All right, Sarah, we got a bunch of information, a little bit more history about, how these episodes were starting episodic, and then he had like a continuous symptomatology that resulted in admission, discharge with aspirin and Plavix, and a little bit more about kind of like his family history and social history. What do you make of the information so far?
Yeah, this is really interesting, and I think is pointing to something that maybe I kind of glossed over a little bit, but this is a young patient who I think we cannot necessarily rule out that they have some kind of, congenital issue. Like, and I in the chat, anomalous coronary artery was like a don't miss diagnosis for young patient. Um, and then also like there's this note about them having consanguinity in the family. So also thinking about kind of inborn like diseases that, I don't know much about and I would, need some help with. And then like this early onset of hypertension, I think also maybe is cluing us into whether there is, disorder with like either the RAS pathway or kind of problems with, thyroid or increases in like epinephrine, adrenaline, something like a pheochromocytoma. So yeah, I think there's a lot that's been shown here. Some things that I think would be really helpful to see for this patient are like imaging of the heart and in some way, shape, or form. Because I I mean, I'm sure that when they were admitted to the CCU, there was like probably an echo done, and um, I yeah, I'm just interested to know what their kind of anatomy of their heart is and whether we've fully ruled those things out. The other things that I'm seeing here are that they have like a diagnosis of panic disorder and, ha are taking like chronic benzodiazepines. Um, whether the like this is maybe a trap that we sometimes fall into that somebody has, a medical condition that is kind of written off as anxiety and then they're prescribed something and then these like maybe more insidious and scary things can be missed. So um I wonder whether that might have been what happened here with this person's chronic chest pain. What are your initial thoughts?
Oh my, sir, you're so good to be able to like get so much information and to be able to pick out the pertinent parts and kind of apply it to both base rate of disease and also this young patient presentation. I 100% agree with you about like where you're leaning with like maybe more congenital hereditary cardiomyopathies that this presentation is invoking. Yeah, I'm like quite concerned. Mohammed, can you just remind me, was ST depression on the lateral leads? Did I read that right? Did I remember that correctly?
Yeah, that's correct.
Okay, wonderful. Um, so, let's start with kind of this episodic episodes that he's had. I think, yes, there's this diagnosis of panic disorder, and yes, this patient could might as well have panic disorders. However, attributing all of this to panic disorder will remain a diagnosis of exclusion. So we're just gonna set it apart for now and just gonna sit here while we think about everything else. I think in terms of kind of like this young patient who is like presenting with this episodic chest pain that is becoming worse over the years with like notable family history. I think that you're kind of like what I think about my no misdiagnosis where we like kind of inherited cardiomyopathy or genetic cardiovascular diseases, as you were mentioned. And like with the lateral ST depression, it would be possible like ischemias, like in like kind of circumflex territory, that could potentially cause it. Could it be just like demand ischemia from like really elevated blood pressures? Sure. Um, but in a 20-year-old, I would often would think about like, oh, is it like a primary cardiomyopathy with like sinus supply demand mismatch that is causing this like chest pains or like ECG changes? As you mentioned, like a coronary anomaly would also explain it, or like more like genetic metabolic diseases. In a 20-year-old, if we want to think about like early, like kind of aggressive atherosclerotic disease, I think that where family history would be really informative. If there's like a family familial like lipid disorders, then this patient could at the age of 20 be more we at higher risk for it. So someone who would definitely, and I'm sure in the past he's gotten lipid panels and we will hear about that. Um, but the one thing that I would like if I'm like working this patient, I'm like an echocardiogram, as you mentioned, would be really helpful because I'm like, oh, are we dealing with like hypertrophic cardiomyopathy? He's young, the chest pain, the shortness of the ST depression, family history of early heart disease, the AICD placements, would be notable of that. So I think like an echocardiogram would be really helpful to check out the LV thickness and like the LVOT gradient. Like the other ones that often you see in a younger is like genetic dilated cardiomyopathies. And I think like I would be curious to know if you know more about his sister's cardiomyopathy. They tend to be more associated with like mutations. And with kind of like the other aspect of it that I'm not sure how much to layer on yet would be like kind of um, learning difficulties that he's experiencing, whether that is like a mitochondrial or storage disease that oftentimes can present with learning difficulties. You mentioned like anomalous coronary artery. It can cause like oftentimes ischemia. So it would be like interesting to have known if you had like elevated troponemia in the past, if it's like a left heart cath was done, to be able to visualize that. The part that I don't know how much, in terms of like the metabolic storage diseases that often can present at a younger age, I think oftentimes you just have to see if there's other clues. Like, is there like any like CK elevation, any myopathies, any neuropathies, any like hypogonadism, any other symptoms that then you can start putting them together and then probably use our friendly AI tools or like up to date or
Yeah.
whatever resource to have to be like, oh, is there any genetic disorders that would, but I think like the most important thing in cases like this, especially as a person who like I don't see like a lot of these type of metabolic like storage diseases, and the last time probably I thought hard about that was like years ago, is to just make sure you are very thorough in your present in your both history taking, family history, and also exams to be able to pick up what could potentially be signals that you're dealing with like a more of a metabolic or like storage diseases, and oftentimes like finding other systems that might be involved is helpful. I'm gonna pause there. I think I can talk about all of these things for a long time. And it's also like I would also put like a question mark with the aspirin and the Plavix. Oftentimes if you think someone has like a ischemic event, we do the depth therapy. We often like add like like a Torvo for our adults as well to decrease their risk. So I'm like curious to know about why aspirin and Plavix was chosen. And I wouldn't let that anchor to only think about like, oh, he might have had like actually ischemic event. So yeah, that's also, I'm not 100% sure why, but we'll just keep it in mind as we go forward. Sarah, any other thoughts?
Yeah, and something that you mentioned earlier, like vasospasm, I think is still on the differential for this patient. Um, so yeah, all the same thoughts as you.
Yeah, absolutely. Like vasospasm, and oftentimes you can think about like substance use disorders, cocaine,
Yeah,
notorious for it. Here in the West Coast, we often see a lot more meth that can do a lot, like cause you to
yeah,
be more hypertensive. And with this patient with a history of hypertension, again, is this primary? Is this secondary?
yeah.
20-year-old with hypertension, are we dealing with? So I think there's a lot of different paths we go down there. But I'm curious to see what the initial workup was, and hopefully we can like narrow it as we go along. That's a really great thought about vasospasm. All right, Mohammed, back to you.
That was amazing. So, as for your concern, and some of the people in the chat mentioning about the dual antiplatelet. So, this patient ECG changes, ST depression, uh, was resolved spontaneously. So, there is concern about this dynamic changes of ischemia. So, on discharge, they started him on antiplatelets. So, as for the examination, it happened in the clinic 2 weeks after his episode. So patient temperature 37 Celsius, heart rate is 72, blood pressure is 130 over 77, and respiratory rate is 16. On general examination, he is tall, thin young man, uh, doesn't look in distress, speak in full sentences, and cooperate with the examination. So, and also have some marfanoid habitus like long arms. His cardiovascular examination was unremarkable for heart sound, and there is no murmurs. And the respiratory examination was unremarkable. Other examination like extremities, also unremarkable. As for the patient, laboratory and imaging, patient has hemoglobin of 13, MCV of 90, white BC of 6. Patient basic metabolic panel, all of his electrolytes are normal. Liver function tests are normal. Renal function tests showing creatinine of 1.4 and BUN of 23. His clinic-based troponin was unremarkable. 2 weeks ago, it was elevated and positive. His resting EKG is normal, and his chest X-ray is unremarkable. His echo shows LVH, normal ejection fraction, and RV dilation. And I will stop here.
Wow. This gets more and more interesting. Um, Thank you so much, Mohammed. This is such an interesting case to think about. All right, sounds like, Sarah, we have someone with like kind of relatively normal vital signs, maybe some kind of this morphinoid features on exam, and largely unremarkable labs with like maybe a creatinine that might be a little elevated. And with some interesting echo findings, what are you making of this?
I think my immediate thoughts here are like I feel like I'm just distracted by wondering whether his sister has like some of the same features and whether I really can start to zero in on like this feels like, syndrome like area of illnesses. Um the creatinine and the heart findings, like starting to create like a syndrome of this patient has marfanoid habitus, cardiac dysfunction with LVH and right ventricular dilation. Um, and then also like so heart, kidney, um, and probably not too much else except for these other kind of like um morphology changes that we're seeing on physical exam. And uh yeah, I would be interested to know what his urine looks like, whether he, like whether we can use that as a diagnostic clue. Um but yeah, like at this point, I think I would be like paging the genetics team, like, hey, can we have some help here? But starting to think about things like homocystinuria and all of the other things that can result in marfanoid habitus.
Yeah, definitely like getting more and more worrisome where some like at least like kind of like genetic like hereditary issue that we're like dealing with. And I love asking for help and for sure. And one of the reasons why I love being a hospital is that I feel like I have a team of experts always with me. So you're never alone. So like I think calling for help in cases like this, like especially like our heart failure doctors, and our cardiologists are also immensely helpful. Um, and yeah, oftentimes like we in medicine, not I'm not saying in this case, we often like throw like kind of morphinoid appearances. In this case, I think like it will be really, really important to kind of really see if this patient meets criteria for Marfan's or this is some like
Mhm.
morphinoid etiology. And do I truly remember all of them? Absolutely not. I have to look them up. However, I think like, they have issues with like some eye issues like dislocation. They have hypermobility of their joints, I believe.
Mhm.
Um, there was some things about hands as well that oftentimes you can look at, but I truly have to look at up to remember like what exactly
Yeah.
fits in like kind of morphin pathology. But the things that fits with it is like kind of the tall, long extremities, like early cardiovascular disease, LVH,
Mhm.
you often see it. And if I remember correctly, in a lot of these type of patients, you can get like early sleep apnea that can potentially cause like pulmonary
Mm.
hypertension. And like they also, I think one thing you don't want to miss in this people is like aortic root dilation that often is present.
Yeah.
And they tend to can also have some renal dysfunction because of the hemodynamic changes they experiences. Um, so uh, so oftentimes like it would be good to review that echo about the aortic root and making sure the aortic root is okay. There are other like genetic possibilities that have like marfanoid appearances and they tend to have like aggressive aortic diseases. I don't, there's like I can't remember the name of it. It's like Diet syndrome or some DE. Sorry.
Lays Dietz. Is
Oh
that the one that you're
yeah,
thinking of?
yeah. I think that
Yeah.
one. That also has some marfanoids. Oh, I'm like reaching back here.
Yeah.
And then the other ones, like I still like you want to. I think at times think about it whether it's like it's you're dealing with like a vasculopathy, like Ehlers-Danlos type of syndromes,
Mhm.
and oftentimes like they tend to have like more easy bruising. And the reason why I bring that up is that these people tend to be at high risk of aortic rupture and death. So
Mhm.
thinking about those would be would be informative. And I think like thinking about the echo itself, like the question is like, okay, he has LVH, which kind of makes sense with the history of like hypertension that he has.
Yeah.
I don't know if that LVH is like primary or secondary. And the other thing about the LV dilation is I often think about LV dilation in the setting of like pulmonary hypertension is the one that I often see, thinking about like the five WHO groups. A lot of the times, like and most commonly, you'll see it like, primary pulmonary hypertension, left-sided disease. Like, is his left-sided disease so bad that it's causing right-sided? Probably in a 20-year-old, I would say no. And then is there any primary right-sided cardiomyopathy that we
Mm.
have to think about? Or in kind of like Marfan type syndromes, you often get valve dysfunctions, and
Mhm.
oftentimes I mostly remember mitral valve prolapse being common in this group,
Yeah.
or rather than like tricuspid that would cause like right-sided issues. But again, are we dealing with left-sided causing more right-sided issue? Um, so I've been kind of thinking of going back, the fact that he had like some troponemia in his last hospitalization. In my mind, currently, I'm like kind of attributing it to like a demand ischemia type picture. However, I think like, making sure he doesn't have early atherosclerotic disease in the setting of like a metabolic disease, as we talked about, still is on my list of doing it. So, I think kind of like what would be my next, what would yeah, let's talk through like what would be our next step if we're in clinic with Mohammed. What are you doing next?
Yeah, my wish list. I agree with you worrying about early atherosclerotic disease, and I'm wondering whether this person got like a cath, to see whether there's any kind of ischemic changes. I in clinic, yeah, that's a great question. What to order? Um, what things do you have on your list?
Yeah, the things that I would want to do is definitely cardiology referral. It's gonna get
Yeah,
that at the end of this visit. But what I was gonna order, I think like just getting like a lipid panel would be really
yeah,
helpful. Hemoglobin
sure.
A1C. The other thing to also, I think at this point, I would want to know is that like if the hypertension is a standalone, is part of it is like, am I dealing with like hypertension being the
Yeah.
primary issues that is causing LVH? So thinking about like, oh, are these like episodic? Is there any endocrinopathies going on?
Mhm.
You can always like send a few workup would be the one I can think of. Renal artery stenosis, sure. but the management of that has now evolved into mostly kind of like medical management. Um, so kind of like thinking about your like hypertension workup, and then I
Mhm.
think it would be like a genetic workup. Like how much of it like you
Sure.
do by yourself, how much of it you refer. I think depends on the systems that you all want to do, but like definitely thinking about like Marfan, Louis Dietz type of syndromes. I can't remember what the genetic numbers
Yeah.
are, to be honest with you, but I would look up
Sure.
those things and thinking about. And the other thing that I would do maybe an eye exam referral, like ophthalmology,
Mm.
to see if those things are true. And then the other thing is just like going through the echocardiogram with a cardiologist to make sure, like taking a look at the aortic root to see what that is. Would be curious to see if there is like evidence of like if the RVSP is elevated, do we have pulmonary hypertension, and if this is someone that like right heart cath would be helpful. In terms of like other imaging, depends again on where you are practicing.
Mhm.
I think you definitely want to make sure you have a good aortic root workup. So whether that's CT angiogram or like making sure your echo captures that. And you know, like if you're lucky enough to work in a system that you can get cardiac MRIs, I would assume
Mm.
like this is a patient that like in the US might be getting a cardiac MRI to look for any myocardial pattern, fibrosis, better visualization of RV and LV function. But I think like that is something that is not available to all, but it could be helpful in these cases. So that is kind of what I would be thinking of doing. So yeah, anything else, Sarah, from your perspective?
No, I think you're pretty comprehensive on that first pass. I'd love to hear more from Mohammed.
Well, thank you everyone for this discussion, both here and in the chat. So obviously, this patient come to us in cardiology, so we consulted
Mm.
everybody, and ophthalmology, also nephrology, and as well as genetic people, our friends. Here we call them rare disease specialists. So the cardiologists um, that say we need to know the anatomy of this patient, cardiovascular anatomy. So repeated the echo and with a similar uh, report. And this patient had a gated CT, chest CT with IV contrast, showing normal coronary arteries, normal aorta, no dissection, but also shows multiple bilateral eccentric organized pulmonary thrombi and arterial webbing in the small segmental pulmonary branches. And CT abdomen was unremarkable. Also, the patient had from neurology recommended doing a brain MRI after this finding. So brain MRI shows multiple lacunar infarcts in various stages of evolution. And I will stop here.
Mohammed is just throwing us all curveballs here, as this thesis is evolving. This is a fascinating case, Mohammed. Thank you so, so much for presenting. I honestly don't know which direction we're going, but I'm happy to be in this ride with you all. Sarah, what do you make of this new finding of like both pulmonary embolisms and multiple lacunar infarcts on the brain MRI?
Yeah, I'll start with the pulmonary emboli. I think pulmonary emboli makes me think of, venous hypercoagulability, whatever cause that might be. And the fact that they have multiple of these makes me think that this is like really a chronic issue that he has had, and whether his shortness of breath is more secondary to the cardiac problems or now that he has like, I guess, CTEPH. Um, I guess I'm interested to know. And then I'm gonna treat the lacunar infarct separately because like lacunar infarcts are typically like small vessel infarcts from things like hypertension, diabetes. Usually you see them, in your older patients with like cardiovascular risk factors and longstanding hypertension or diabetes. So I I would be tempted to kind of treat these as two separate problems that probably have a common source problem, which is whatever his underlying genetic condition is. And think of the lacunar infarct probably as like, probably as hypertension or potentially like whatever is making his blood more hypercoagulable. Um, so yeah, that's where I'm at on that. What do you think?
No, I love your approach and I love how you reason, Sarah, because oftentimes like we want to just clump everything. And I don't think that is always the correct way when it's you're doing your first pass. So I loved how you were like, okay, I'm gonna separate out the pulmonary emboli from the lacunar infarct. I'm going to think about them separately, and then I'm going to think about if they can be related to each other or not. And I think that is an excellent way, especially when you're like doing your first pass to kind of like think through an etiology. And yeah, you're absolutely right in the sense that like, oh, this is a big pivot point, right? Like this patient is having like a systemic hypercoagulable disorder until like proven otherwise. And both he's having both venous clots in a setting of like what pulmonary embolisms that we've seen, and also he has like arterial clots in a setting of like probably the strokes, the arterial clots that we're seeing most likely. And I think like the one thing that you often don't want to miss in this situation is antiphospholipid syndrome, that you're like getting like kind of clots everywhere. So like this is like where you want to send your lupus anticoagulant, like your cardiolipin, your anti-B12 glyco protein. And mostly because the reason why it's important to think about antiphospholipid syndrome is because the treatment is different, right? This is one of the only situations where we still use warfarin in addition to like mechanical valves. So that is like important if you see both arterial venous clots or like really terrible clotting, think about antiphospholipid syndrome, send it because the treatment would be different in this case. The one thing that I was thinking with it, like his RV dilation, I was like, does he have a PFO that is like leading into kind of paradoxical embolism via the PFO that could potentially kind of link these two together? So, like, I think getting a TTE with a bubble study would be the next step to make sure if this patient has a PFO or not, especially if you're dealing with like elevated right sided pressures. And I really love that you brought up CTOF, which could potentially like explain pulmonary hypertension that can cause right-sided heart failure. That was really awesome, Sarah. And again, like the other inherited thrombophilia eh, oftentimes like less likely to be arterial. So you're a factor of five light and those type of things. Um, it's probably a little less likely. The one thing, like if I take a step back and I'm like, okay, is a little, and you mentioned this in this given like kind of the myofrenoid stroke is like homocystinuria. That can cause both arterial and kind of venous clotting. And given like the learning difficulty, the thrombosis that we're seeing, kind of probably like a history of like a consanguinity that is present in this case. I think that also like with the clotting jumps higher on my differential. And I think like for that, we want to check like plasma homocysteine levels. And I think the other things that I would like think about in older folks would be kind of like vasculitides. Kind of feels less likely in this case. Most likely we're dealing with like kind of a genetic conditions that is presenting like this. So that is like I think I would do more of a hypercoagulable workup, and I think like really paying attention to like kind of the homocysteine urea. Any other thoughts, Sarah?
No, I think that you did a great job summarizing where we went, like went previously and where we are now. I think one thing that did kind of jump to my mind while you were talking is like the way that I think about like cardioembolic stroke and like where I mostly have seen those strokes show up. And a lot of times I think of those as being like cortical. And maybe that's like wrong, and I should be thinking about that as a cause for lacunar strokes as well. But yeah, that was just one little thought that I wanted to share.
I think
But
you're correct. Yeah. Yeah. No, I
yeah,
think it's most likely presents like this. For sure. Could
yeah.
be could be different in this case, sure, but no, I think that your understanding is spot on.
Okay. Well, we'll pass it back to Mohammed.
Thank you again for this discussion. It was very amazing. So at this point, after seeing multiple fingerprints of maybe infarction, we sent for coagulation panel, and it was unremarkable. Autoimmune also panel, ANA, as well as antiphospholipid syndrome also was unremarkable. At this point, the patient was transferred to uh, follow up with rare disease specialist, and they did their work and sent for blood tests. They test for blood homocysteine was 145 micromole per liter, which was elevated, as well as there is an elevated methionine, 5 times the normal limit. And I will stop here.
What a journey. Sarah, you're just absolutely have been brilliantly discussing this case, by the way, and love the point about the stroke you just made. It's just beautiful. All right, Sarah, what are your thoughts on the latest finding?
I mean, I got my initial thought is that I got to give credit where credit is due, which is to the chat for for bringing up all of the genetic disorders that like would have been really hard for me to pull out of the back of my head, and I probably would have needed Google to think about them in the first place anyway. Um, so yeah, my initial thought of like, is this a younger patient with something genetic or congenital, I think is an important thing to remember when we're thinking about younger patients. Um, and yeah, I've never seen like homocystinuria in person, so I wouldn't really know if I would initially think about it. And I know that when we're doing like stroke workup, we always send like serum homocysteine as part of the kind of coagulation uh milieu of stuff that goes out to the lab. But it would be interesting to see something like that come back positive and then have to go back. I think I would find myself going back to the patient and seeing whether, like, after the fact, I saw any of those like morphologic features. Um, what are your thoughts here?
Yeah, and I think, oftentimes, like at the end of the day, what our patients deserve is the full resources that we have ourselves and whatever resources we have access to. So I think like whatever external brains we like to use, we should use them like as same way we call consultants, we can use our external brain and always like being curious of like what we're missing, learning more. And I think like, that's how we learn. There's still so much of medicine that I don't know that I'm learning. So I think your instinct of like, I have to look this up is a great instinct to have. It's much more, I think in medicine is better to be like humble and curious than confident. So I think you are well on your way of becoming an incredible physician, Sarah. And in terms of like this homocysteine levels of being methionine, sorry, I can't pronounce it, being elevated clinches the diagnosis of homocysteine urea. And I do not remember the pathological, like the pathophysiology pathway, but I remember it actually, it's really, really cool. What I know of it is that like kind of like the presentation of like what we talked about, it causes a lot like homocysteine uh like this type of elevation causes a lot of endothelial dysfunction. It causes like increased platelet activation. So you tend to be more like hypercoagulable. And these patients tend to have like Marfan versus homocystinuria. You see this in this population. They have like some overlapping feature, but like the clotting makes homocystinuria more likely than Marfan syndrome. And they tend to like it explains like the pulmonary embolism, the lacunar infarct, probably LVH, the renal dysfunction as well. So it would be interesting to see if the sister had a similar condition that we are seeing. And the other thing is like in Marfan, I don't think developmental delays is that common. So I think that also points more to like homocysteine, urea as well in this case. And the other thing that I was going to say about this is that in terms of like acute management, you definitely full anticoagulation for this patient. They will require long-term anticoagulation, and the treatment is actually a metabolic treatment, is like vitamin B6. Often these patients are responsive to it and allows like the homocysteine levels. And if you see like the homocysteine levels drop in response to B6 treatment, that is like better, like a better prognostic factor. And you also want to like supplement with like more folate and vitamin B12. And I'm sure Mohammed can teach us a little bit more about the pathophysiology of that. But that's what I remember. That then you also want to make sure they're like in a protein restricted diet, like protein not restricted, modified diet. It's like how I kind of like think about this disease. So again, I think like going back to that echo finding, I think that right, like now I'm like thinking the right artery dilation, as you mentioned, was like mostly like the pulmonary emboli, and that was like causing it. So yeah, such a fascinating case. Amazing job, Sarah. Mohammed, teach us more. Tell us more.
I have nothing to add, Charmin and Sarah. Very wonderful discussion. So this patient with suspicion of homocystinuria, uh, people genetics have gone further into gene expression tests and confirmed the diagnosis. So there is a precaution to everyone. I will say some genetic things. So we have a homozygous pathogenic variant in the CBS gene, which is responsible for homocystinuria. So as you mentioned, Charmaine, treatment, we have to do empirical things, maybe homocysteine restricting diet. So we started the patient on B6, empirical B6, B12, folate. So in this patient, I want to emphasize two things. First, the homocystinuria, as in many case reports, have been associated with arterial and venous thrombosis. So for the this patient have lacunar infarcts as well as pulmonary. So this show that these people are more prone to thrombosis. Consanguinity of this patient, family history, especially in his sister, maybe there is a possibility of combined genetic problem. So in addition to homocystinuria, maybe there is something related to cardiomyopathy. So these are my two teaching points of this case, and thank you everyone for your discussion.
Oh, Mohammed, you're so awesome. Thank you. You like presented this case so beautifully. All the aliquots were so well done. I hope you come back. I hope we get to hear more cases from you. This was absolutely brilliant. Like, I haven't thought about these diagnoses in a long time, and this is one of the reasons I love VMR. It always pushes me, and I get to learn from all of you. Sarah, any additional thoughts from you before we hand the mic to Dodmer?
No, I just want to thank you for bringing the case as well, and I'm so grateful to learn from you.
Sarah, you're brilliant. Absolutely amazing discussion. Hopefully we get to do this soon again. Thanks all for joining us. Really appreciate it. And Dodmer, we're ready for your teaching points.
Great discussion and great case. Thank you, Mama, for bringing this case to us. All right, so we started in the beginning talking about chest pain and shortness of breath since the patient was a young person presenting with chest pain and shortness of breath. And we mentioned that we gotta think about the dangerous diagnosis first. So uh, ruling out those first, especially if the presentation is acute. When the patient comes in with a chronic issue, it's also important to distinguish whether or not they're like why they're there, why they presented at that point in time, whether it's the acute on chronic or if it's a pure chronic, then that they just decide to come in at that time. Um, And since the patient was a young person, we were thinking about the different causes for like ischemic heart disease, which could potentially present as ACS. And we mentioned that given the age, it is less likely to be an atherosclerotic. However, we still do consider hyperlipidemic syndromes, so like familial genetic syndromes. Um, but vasospasms or dissections could still like, would be higher on differential if we're thinking about ACS in the patient, uh, and some sort of anomalous anatomy in the coronary arteries. Uh, since the cardiomyopathy was in this young person, it was in a young person. The potential cardiomyopathy was in a young person. We were thinking also about rheumatic heart disease, genetic cardiomyopathies, and metabolic storage diseases. But specifically for the storage diseases, we were also looking for more signals in the history to point to um, any other abnormalities. Um, and in a situation like this that we had a myofibrotic habitus, it is important to consider genetic connective disorders like Marfan syndrome or Loeys-Dietz, since it could have consequences that are very dangerous, such as aortic root dilation. And when we found out about the venous and arterial clots, that kind of narrowed down our referential. And given that APLS would have a different treatment compared to all other hypercoagulable states, um, it's important to consider that early on. And given the both even the very very high hypercoagulable state, uh, it could either be the blood that's super coagulable, or if there's some sort of connection between the right side and the left side of the heart. So we would also consider bubble studies at that point. And putting it all together, homocystinuria was a possibility in this patient, given the family history of multiple genetic disorders that happened early on, given the learning difficulty, given the body habitus, and the hypercoagulable state. So uh, for that, we check the homocysteine and methionine levels. And in terms of long-term treatment of homocystinuria, it would be especially since this patient presented with a lot of coagulability, long-term anticoagulation, vitamin B6, folate, B12, and a methionine restricted diet.
Oh my gosh, Admir, that was so, so good. Thank you so much for doing such a great job of like summarizing all the teaching points. I don't know how you all do it in a moment. It's very impressive. Anyways, thank you all so, so much. Big shout out, Jillian, for doing scribing and keeping up. It was awesome. Thank you, Mohammed. Thank you, Sarah. Y'all on the chat are amazing. See you all next time.
See
Bye.
y'all later.